Hi everyone, good afternoon. We're going to get started with our webinar. So first of all, I'd like to welcome you to our webinar, Promoting an Integrated Approach to Mental Health and Aging, hosted by the Mental Health Commission of Canada. My name is Alexa Bohl and I'm the Manager of Knowledge Mobilization here at the Commission. I just wanted to take a few minutes right here at the beginning to highlight the Mental Health Commission of Canada, who we are, what we do, and how that ties to mental health and aging. Just as a housekeeping item, if you have any questions that come up during the webinar, please feel free to enter them in the Q&A box so that we can address them at the end of the presentation. You can also indicate in the box who you would prefer to answer the question. So now moving on to the Mental Health Commission of Canada. So a brief overview of who we are. We were formed in 2007 by the federal government to lead the development and dissemination of innovative programs and tools to support the mental health and wellness of Canadians. The Mental Health Commission's current mandate aims to deliver on priority areas identified in the Mental Health Strategy for Canada in alignment with the delivery of its strategic plan. So a little bit about how we do this. We're funded by Health Canada, and we convene stakeholders, develop and influence sound public policy, and seek to inspire collective action. So each of our initiatives and projects are led by experts from across the country who bring a variety of perspectives and experience to the table. Consulting with people who have experience living with mental health problem or illness and their families is a key aspect in all MHCC's work. The MHCC provides its recommendations to governments, service providers, community leaders, and many others, and works with these partners to support their implementation. So what has the Commission been doing about aging and mental health? To start off, the Mental Health Strategy for Canada frames our work in this area. Among a total of 109 recommendations, we address aging and mental health with recommendations that speak to things like countering age discrimination and stigma, promoting wellness, education and literacy of the public, focusing on intervention whenever possible, and improving access to care, including better collaboration and coordination. As a part of addressing and outlining some of the recommendations and evidence in seniors' mental health, the Commission, in partnership with the Canadian Coalition for Seniors' Mental Health, compiled and published a guidelines for comprehensive mental health services for older adults in Canada. This was originally published in 2012, and we did do a reprint in 2018. The guidelines provide a number of recommendations across different areas of the service system to support the mental health of older adults. The purpose of these guidelines is to support the planning, development, and implementation of mental health services that respond adequately to the needs of the older adult population in Canada. So currently, MHCC has a few initiatives on aging and mental health. So one of them is the promotion of the uptake of the guidelines that I just highlighted through some knowledge mobilization efforts. And as you can see here on the screen, number 2 and 3 really build on this first initiative to support organizations and service providers to use and implement the recommendations that were highlighted within the guidelines. So in order to do this, we created an updated summary document with current information and sources that link back to the wisdom that were presented in the original guidelines. So this summary document is due to be released this October, probably toward the end of the month, so stay tuned for that. And then to complement that document, we've also compiled a compendium of good practices for improving seniors' mental health in Canada. So without seeking to be comprehensive, the examples used in this compendium illustrate some of the ways services in Canada have begun to implement the guidelines. While we recognize that many challenges remain with respect to meeting the mental health needs of older Canadians, the hope with this particular document is that this will inspire and support further developments by building on the experience of the many hard-working healthcare providers and planners who have already established model services and programs. So a little bit about this compendium as we start to focus in on our topic for today. Based on discussions with leading experts and key informants, we realized that planners and administrators needed more information on how to apply the guidelines recommendations to improve services in their local communities. So this compendium, which is due to be released at the end of October, uses Canadian examples of well-integrated or innovative services across a range of resources and demographic profiles within the realm of seniors' mental health. It's meant to help planners implement the guidelines model of mental health services in their own communities and jurisdictions. So within the compendium document, you'll see 8 different sections listed out here. So the model services and programs are highlighted from across 8 areas that are spoken about in the guidelines. And for our purposes today, we're going to be focusing in on promotion and prevention. So in today's webinar, we're excited to highlight 2 excellent examples of innovative programs in Canada that are featured within the compendium document that address the area of promotion and prevention. So our first example today is going to be from the Fountain of Health and will be presented by Dr. Carrie Lee Cassidy. Dr. Cassidy is a professor of psychiatry and the clinical academic director of Dalhousie's Geriatric Psychiatry Program, the Nova Scotia Health Authority. He is the founder of the Fountain of Health, a national nonprofit organization for knowledge translation promoting brain health and resilience. He is a national leader in late life psychotherapy, past lecturer on late life psychotherapies for Canadian Academy of Geriatric Psychiatry National Review course, and the author of a manualized enhanced CBT group therapy program. Dr. Cassidy is the recipient of several national awards, including the 2016 CAGP's Outstanding Contributions in Geriatric Psychiatry Award, the 2018 CIHR Betty Havens Prize for Knowledge Translation and Aging, and the 2019 Canadian Psychiatric Association's Award for Creative Professional Activity. And then following Dr. Cassidy, we will have Denise Wallagora, Training and Delivery Specialist with the Mental Health First Aid Canada, and she will be speaking about mental health first aid for seniors. Denise has a Bachelor of Science degree and over 20 years of working in the mental health field. Prior to joining the Mental Health Commission as Training and Delivery Specialist for the Mental Health First Aid in 2011, Denise's professional experiences included psychiatric nursing, residential program director, IBI therapist at CHIO, crisis worker and case manager in a justice program. Denise has been facilitating MHFA since 2008. So now without further ado, I will introduce Dr. Carrie Lee Cassidy to talk to us a little bit about the Fountain of Health. Dr. Carrie Lee.
Okay, great. Thanks, Alexa. And I look forward to hearing the following up section on mental health first aid for seniors. It's a very exciting program too. And I really appreciate very much this opportunity. So thank you for the invite to present on the Fountain of Health to this audience. As you can see, it's intended to be a national initiative for promoting brain health and resilience. But for this to be actually useful, it needs to be used. And so it's very helpful that there are opportunities like this to share the information across the country. As Alexa mentioned, this is a nonprofit association, and it's really intended for knowledge transfer, translation. And the goal is to improve health outcomes through health behavior change. And there are 2 main arms of our knowledge mobilization work. One is KT for the public with information and resources. For example, we have a website, fountainofhealth.ca. There's a speakers bureau. People can request talks. We have a 4-week community-based workshop series, and then more recently this past year an app. And the goal is really just to make sure we're mobilizing information about brain health and resilience and what current science tells us that we could be doing to promote our brain health. The second key arm is more for the professional audience like this one, with resources for healthcare providers and anybody who's in the healthcare system. And it's really to take it to the next step, not just the did you know, but then can you do behavior activation that would allow for more people across the country to have the kind of coaching that's needed to support health behavior change on a wide scale. And the approach takes tools that are used by subspecialty experts like myself in cognitive behavior therapy that really work for severe illness and disease and behavioral disturbances, and takes the most essential components of that and makes it widely available for everybody to be able to access in a very brief intervention. Obviously, work like this isn't done in isolation, and I just want to acknowledge a number of people, in particular, and not everybody who's involved with the leadership team is listed here, but we have representation from sort of my professional umbrella of my career, which is the Canadian Academy for Geriatric Psychiatry, but also the Canadian Coalition for Seniors Mental Health. So this is Dr. David Kahn and Kieran Rabaru, and the two of them have just been phenomenal in their support for the Fountain of Health and assisting in the mobilization of knowledge across the country. And I don't yet have another person's photo up here, but looking for Claire Checklin's photo. She's the executive director for the CCSMH, and she may even be on the line today. So if you are, Claire, we can hear from you at some point in the Q&A. Also representation from the Canadian Medical Association, the Geriatric Society, and the International Longevity Center. There's Alzheimer's Society Canada, the Canadian Mental Health Association, and others who are involved with this work. But I've been incredibly grateful for the support among my colleagues and other nonprofits in supporting this agenda. So just again, to acknowledge some of those partnerships, and in addition to the CCSMH, the Canadian Centre for Aging and Brain Health Innovation has offered very generous support to our project. In terms of why this is needed, it's not a new idea to think that prevention is worth a pound of cure, but these are, wise words. But what's been helpful is that in recent years, documents like the one we were just hearing about from Alexa about the guidelines for care of older people was a document that really influenced me. So if the Commission's hope was to inspire collective action, it certainly worked in my case. I looked at that and I noticed that 30% of the entire document was dedicated to prevention and recommendations around that, and it really made an impact and got me thinking about what that really means. And around that same time, there was also the Rising Tide document that was published by the Alzheimer's Society of Canada, noting that 4 action areas really that a collective action around prevention could, or risk reduction could delay and or prevent the onset of up to 30% of dementia cases. And so as a geriatric psychiatrist working in the field, looking at the numbers of people growing older for the first time in Canadian history, we're having population aging in a way that's never really been experienced before. I thought a lot about what does prevention and health promotion actually mean? What does it mean to me? What could it mean through the course of my career to contribute to that cause? And looking into the literature, it's fascinating when you actually dig a little deeper to discover that lifestyle is really a lot about what we mean when we talk about health promotion and disease prevention. That our lifestyle has a great deal to do with it in terms of things that we actually have some control over. And what's very encouraging and optimistic is to learn that through twin studies, we now know that only 25% of human longevity is accounted for by inherited family genes. So this means that there is much more in our own hands, what we call epigenetic factors, like our lifestyle, even our outlook, our environment to a degree that really has a huge role to play when we're talking about health promotion actually means. And so in summarizing the literature the Fountain of Health came up with these areas, there's nothing particularly surprising or rocket science about this. No one would be surprised to learn that physical activity is vital to promoting your health over the course of your lifespan, or that social activity is absolutely key, that challenging your brain with new learning is also vital. But I think the Commission would be pleased to know that when you do a search on literature about what actually promotes well-being across the lifespan, taking care of your mental health is at the core. So thinking about what things people can do preventatively is important, and that's included in this initiative. And the other that may be a little less considered is the other aspect of our mental health includes not just our emotions and so on, but it's actually our thoughts. And so what we choose to dwell on or think about has a huge impact on our health behaviors and even health outcomes. So that's also included. Now, I won't belabor too much all the literature around this, but just a few fun facts for you to think about. Did you know, for example, that light physical activity for even 15 minutes a day has been shown to increase life expectancy by 3 years? It's a really substantial amount for just a little bit of physical workout. That exercise is probably the most powerful promoter of brain neuroplasticity across your lifespan. So continuing to move your body is vital to brain health. Exercise is also now a first-line treatment of mild to moderate depression, and is also recommended as an augmented approach to the treatment of severe depression. The Lancet report from 2017 heavily emphasized the role exercise could play in lowering dementia risk as well as delaying the onset of dementia. Another key to know about social activity is that it improves health in ways that have actually been quantified. Are people able to hear okay? I see a few notes about trouble with sound, but I just want to make sure I'm audible. So that there's some research now showing that loneliness has a health risk factor of a magnitude that's similar to obesity and smoking, things we think a lot about in healthcare. We don't necessarily have as much concept around what we could do to help people with their social activity, although there's been more work on that in recent years. Fascinating study out of Harvard. It's the longest study on adult development in the world, and it's been going on now for over 75 years. And that study has shown that secure relationships are actually the single best predictor of well-being across your lifespan. So social activity, social connection to others is vital. Again, in the Lancet report, higher education was identified as being key to brain health, and together with other lifestyle factors can contribute to reducing dementia risk by up to 35%. And that other study that's really worth mentioning is work by Becca Levy and others on outlook on even on aging itself, that looking at our way we think about aging has an impact. And when they study people with a more positive view about aging, they found that people live 7.5 years longer than those with a negative view about aging. So actually assessing people's attitudes about aging turns out to be quite an important part of promoting people's health, physical and mental health. And finally, around taking care of mental health in terms of what does that actually mean? How do we promote our mental health? Well, the evidence would suggest that there are many things we can do under the umbrella of self-care and daily routine that would help. Yoga has strong evidence, mindfulness, getting a sufficient amount of sleep, and having good nutrition, including omega-3 fatty acids and the Mediterranean diet, are all really good for mental health and brain health as well as physical. It's important that we know what the signs and symptoms of mental illness are, so getting people out of the dark in terms of what to look for, and reducing the stigma around that goes hand in hand with understanding it better. And finally, that people who start to see signs and symptoms actually have access to treatment, but also that they seek the treatment, and that they're aware of the biological but also behavioral and psychological approaches that have very strong evidence and are worth accessing and advocating to have more access to. So those are the aspects that the Fountain of Health covers in terms of the content. We know with all of this good science what we should do that would actually promote people's brain health, wellness, resilience, but how do we bridge the gap between just knowing about it and doing something about it? And that's really what the Fountain of Health is aiming to do, is taking things beyond KT and getting translation into action. So in terms of that spirit of trying to bridge the gap between knowledge and action, we developed some resources. As mentioned earlier, we have this website, so you're welcome to visit that at fountainofhealth.ca. And the content is, it changes periodically. There's newer content on there now, but you can easily find the buttons that tell you some of the key things you can do and learn more information, watch a video. The app is available right on that main website, so please feel free to take a look. But also there's a speakers bureau. You can request a speaker. And there's a section that's just for clinicians if you're a healthcare worker and you want to take a look at that material. Please do. Also for the public, in addition to the website and the bureau, there's workshops, and we've evaluated the impact of the workshop series by running them in the community, mostly here in Nova Scotia, and a 6-week version of that. And one of these projects was in collaboration with our provincial Canadian Mental Health Association. We have another one running now with retired physicians of Doctors Nova Scotia. And so we've tried it in different ways, but we've found in the various pilots that when people undergo this series, when evaluated before and after, there are statistically significant improvements in their knowledge, but also importantly, their application of that knowledge to their daily lives. So people are saying they're learning things and applying it to their behaviors. Interestingly, self-perceptions of aging also improved through the course of this. And I should note that we were asking for people to recruit in the community people who are 50 and over. So it was somewhat geared more towards the mature population, older population, but self-perceptions of aging improved in the series. Now that second arm of the project is really where the translation into behavior change is focused, and there are clinical tools, the Health Behavior Change Toolkit, with quick, simple approaches that harness the power of cognitive behavior therapy in a 5-minute kind of interchange between a physician or any other allied health clinician or others in the healthcare system with a client. And the client can then set a goal and follow up. And so whether that worked, we tested initially mostly in Nova Scotia. We had over 500 people who went through that process with a healthcare provider. And we were very pleased that the outcomes were positive, with about 80% of people who went through that process reported they had at least a partial attainment of the goal that they set in terms of one of these 5 domains of health behaviors, with some people fully meeting and others exceeding the goal that they set within a few months. And those who used the beta app, which was the early version of the app, had an even higher rate of success, as well as the majority showing significantly improved self-rated well-being measures or attitude measures, which was also encouraging. And clinicians seemed to like the approach. So with that kind of evidence of effectiveness behind us, we approached our partners, the Canadian Coalition for Seniors Mental Health, to ask if they might be willing to help lead a project to share these materials across the country. And so we're very grateful for the leadership by the CCSMH and Claire and David and Kieran, who really put their backs into supporting this initiative. And of course, many of you will already be familiar with the CCSMH, and Alexa mentioned some of the projects that they've been involved with already. But you can check out their website at ccsmh.ca. There are national guidelines around many different mental illnesses, as well as substance use disorders that are coming out now. And you can join the CCSMH for free, so you can get their newsletter and so on. So I'll encourage you to check that out. In terms of the funding for this initiative, we received funds from the Center for Aging and Brain Health Innovation, which allowed for, and also the Nova Scotia Health Research Foundation, which allowed for the project to run this past year. So to acknowledge their support as well. So just very grateful for having the kind of funding that allowed for this to be shared more widely. In terms of what we ended up being able to accomplish in the past year, together by using the tremendous experience in KT that the CCSMH has, we were able to reach over 2,000 healthcare providers with a 30-minute educational module. A third of the clinicians actually registered to receive the behavior change toolkit I referred to earlier. The majority, vast majority within Canada, but interestingly, somehow external to Canada, we also picked up some interest, and you'll see the flags of the various countries that represent the international group. And below, you'll see that by province, the majority, or the 50%, came from Ontario. But there's a nice spread across the country. And in terms of clinician types, the majority, the largest percentage, I should say, were nurse practitioners. And then we also had a lot of social workers and physicians, as well as others. So we had a nice sort of cross-section of clinician types. And then those clinicians who received education were asked to use the materials in practice, and the client demographics that we heard back about were an average age of 69 years of age for people who use the paper-based tools, and about a decade younger for people who ended up using the app. The majority were women, 70%, and the majority set a physical health goal. So that's what we heard about in terms of the description of the people that were reached by the clinicians. And what we asked the clinicians to do, very briefly, was to assess, while working in the normal course of care, assess their client's baseline to find out what their attitudes were, their outlook is on their current health status. For example, it's hard to see this, but like the first question is, how would you rate your sense of being socially connected to others? And then it goes down the 5 domains where you would rate sort of 1 to 10, or 0 to 10, how you feel you're doing right now. And that's a really important part in CBT, is to assess your own view of yourself. So then with that step completed, then the clinician can work with that client to help set a health goal. Obviously, they could choose for themselves, but there might be a rationale to look at an area where there's room for improvement, relative area of weakness, or it could be the opposite. You want to build on the person's strengths. So just making a rationale, and then they work together to find what's called a SMART goal. And this talk doesn't get into a lot of the details of the technicality of what's being coached, but it is very brief and just takes 5 minutes, and so clinicians are able to incorporate that into their busy workflow. The other key step and secret to success is the follow-up. So then the clinician's asked to check in again about a month later, either in person or by phone, to find out how it went and notice any progress, and then document that. So the clinician has just one piece of paper per client, very simple, for the visit 1 and visit 2, to be able to check in and find out how it went and whether they achieved their goal or not. And the patient has the option to also track using the app, and that's just a couple of screenshots of what the app looks like. On the left is a calendar where you can check on when you've completed your task, and on the right, rate how ready you feel to do your task on any given day, and the menu that allows you to search other sections, such as getting some encouragement, inspiration for ideas, how to go about setting goals, and so on. And through the app, people receive notifications and reminders about their goals to help them stay on track. So in terms of the results of having these 700 different clinicians trying this out with their clients, what we heard back overall about the patients or clients is that, as mentioned, the majority set their goal in physical activity. So this just breaks it down, paper tools versus app users. And so you can see that. What's interesting is whether people used paper or app, the ranking of what was most common was similar across the board, with the exception of maybe a few more people were using the app for a positive thinking challenge or goal, and otherwise very similar down the board. In terms of the paper tool users, so people who were filling out the forms and so on, working with their clinician, the total number of tools that were returned to us were for 380 different individual patients. The mean age, as mentioned, was 68. And what was really heartening was, despite having to basically do a lot of this KT through webinar rather than any kind of close provincial face-to-face as we did with our initial pilot, we still had really strong results. In terms of patients' goal attainment, 90% almost at least partially achieved their goal, which was even better than our first pilot in Nova Scotia. That an even higher percentage reported experiencing some improvement in their well-being. And attitudes also changed, statistically significant differences in their self-rated well-being scores before and afterwards. And then in terms of the app, we had over 500 app users and the mean age of 52, and they did just as well or better, with 90% at least partially achieving their goal, 80% having some improvement in their self-rated well-being, and also a statistically significant difference in their health attitudes. So what we felt was that the results really would suggest that we can recommend this approach, and that it's showing that there's some results in terms of implementing what was recommended in the mental health promotion guidelines of the commission, that we really want to see basically improvements in people's well-being and mental health. And so it's nice to see these kinds of results. We also had a survey that was just finished, and this is hot off the press, some testimonials that came back in comments from clinicians who were surveyed. One person said, "I've been very impressed that even patients I've seen for years and years are open to trying these change tools. Many are appreciative in suggesting a new approach and eager to participate. My patient's rethinking what successful aging means to her. She's definitely more positive and took up 2 new physical activities." And third person said, "Setting a goal gave the client confidence to try a new activity, a yoga class, and also meet a few people. The questionnaire provided a visual way of measuring progress." So I'm just conscious of the time, but I wanted to wrap up just by saying again, so pleased to share. This is actually the very first time the results of this project are being shared, and it's exciting to tell you about it. But to have these approaches, behavior change tools, have them be useful, they do need to be used. And so we'd invite you to explore the Fountain of Health website, explore the Clinician's Corner, and also you can learn more about the Wellness Project and access the Wellness app directly. You can try this out with clients, caregivers, or even yourself. Certainly we're all on the journey, aren't we, for improving our own self-care, well-being, and striking the balance to manage our stress over the course of our lives. If you have questions, for feedback, you can reach out at info@dartmouthhealth.ca. And I'll just like to stop there and ensure our next speaker has sufficient time. And thank you very much for your interest.
Well, good afternoon, everybody. Dr. Cassidy, thank you very much for that informative session. I just want to make sure that everybody can hear me clearly. And now I'm going to take the opportunity to talk to you about mental health first aid seniors, an innovative approach to supporting seniors' mental health. So what is mental health first aid? So mental health first aid is a 2-day evidence-based course, also certified, so all participants do receive a certificate for full attendance. But mental health first aid is a program that participants, when they attend, they learn how to provide support to a person who is either developing a mental health problem or experiencing a mental health crisis. And that first aid is given until appropriate professional help is received or until the crisis is resolved. But also with mental health first aid, it's not just about supporting individuals that are starting to develop mental health problems, because as we know with seniors, often seniors have lived with mental health problems throughout their life. It's also about supporting those individuals in your life that currently live with mental health problems, but may be starting to experience more changes in behavior or those signs and symptoms because of different stressors. So 2 things that mental health first aid does not do. Obviously, in 2 days, we cannot teach you to become a therapist or a counselor. We also cannot give you the skills to diagnose somebody. What we can teach you in a 2-day course is to be more aware of those changes in behavior, those signs and symptoms of various mental health problems, and how to truly be the best support that we possibly can be. As well, mental health first aid, we don't teach you how to fix the issue. We teach you how to support the individual that is currently struggling or living with mental health problems. So let's take the talk to you about what is our mental health first aid seniors. We do have 8 different versions of mental health first aid. Obviously, our seniors course is more geared towards seniors 65 and plus, those living with mental health problems. So the seniors course was put together. It was a combination of work between the Commission, the University of Toronto, and the Trillium Health Partners. As well, just a little bit information on the project background there is that with Trillium Health Partners, they put together the curriculum for the adaptation. The OISE, Ontario Institute for Students in Education, they were responsible for the learning design of the program. The funding for the project, even though, as Alexa had pointed out at the beginning of the session, is that the Commission is funded through Health Canada. For any adaptations that Mental Health First Aid puts forward, we do require funding, and GlaxoSmithKline, they provided the funding for the project. As you can see here, it was an unrestricted educational grant. One of the things we don't talk about in our course is we don't talk specifically about medications. It's really around how to recognize those changes in behavior and how to be that support. As well, all of the resources in our all of our mental health first aid courses as well are from Canadian resources. But specifically, as we talk about the seniors course, we received information, those resources from the National Guideline for Seniors Mental Health, Caregiver Strategies, Delirium Resources, Alzheimer Knowledge Exchange, and the Canadian Census. So as you can see, all of the information, our resources, our references for the Mental Health First Aid Seniors course are all Canadian. So I love this quote here: "Caring for our seniors is perhaps the greatest responsibility we have. Those who walked before us have given so much and made possible the life that we all enjoy." One of the things that we realize is that seniors do bring a lot to our lives, and it is our responsibility as seniors age to provide them with the best care, for their health, for medical health, and for their mental health as well. So why do we need mental health first aid seniors? Dr. Cassidy had alluded to as well the increasing population that we have of seniors across Canada. But as of July 1st, 2015, there were more people aged 65 plus than children under the age of 15. And by 2030, which is just in 10 years, nearly 1 in 4 Canadians will be a senior. And currently, I believe our population is just a little over 36 million. So 9+ million Canadians will be seniors as of 2030. As well, the likelihood of experiencing a mental health problem or illness in a given year increases as of age 69. The evidence does show, and I'll talk about that in a couple of minutes, the link between the physical illnesses and mental health problems. And as well, currently, men aged 80 and older have the highest suicide rates in Canada. And we're also looking at the fact that family members who are friends our caregivers have also been shown to have high levels of distress. The evidence has shown that 3.8 million Canadians aged 45 plus are those informal caregivers for seniors in their life. So when we take a look at the statistics around depression and statistics around anxiety, when we look at 13% of Canadians at some point in their life will live with a mental health problem, we think about the number of caregivers, those informal caregivers that are taking care of, whether it's parents and elderly parents or elderly grandparents. We're even looking at seniors taking care of seniors. So we think about the fact that seniors, themselves, that, those caregivers themselves that live with mental health problems, and the stressor possibly of becoming that informal caregiver, we know as well can affect the caregiver's mental health as well. And that's one of the unique points about the Mental Health First Aid Seniors course, is that we talk about support for the caregiver as much as we address support for the senior living with a mental health problem. So when we take a look at Canadian seniors living with mental illness, there's 4 distinct populations. So as we see here, those that are growing older that currently live with a mental health problem. But the one thing I want to point out is the last bullet point, when we look at those living with chronic medical problems with known correlations. So for example, we know that there's a link between those living with depression, and there's a link between cardiac disease, so heart disease, stroke, diabetes. So for example, somebody that experiences a stroke puts them more at risk for experiencing depression. There's a link between heart disease and depression. Those living with diabetes are more at risk for developing depression. Those living with depression are more at risk for developing diabetes. So we see that link, and in our course we talk about addressing those physical needs as well as we talk about addressing the mental health needs of seniors as well. So we talk about stigma. We know that there's a huge amount of stigma when it comes to those living with mental health problems. Stigma is a serious barrier to people seeking treatment, to people seeking support, even to receiving support for living with mental health problems. There's a big myth out there that individuals living with mental health problems are considered violent and dangerous. Whereas the evidence actually shows that those living with mental illness or mental health problems are more likely to actually be a victim of a crime than they are to commit a crime. That people are weak or to blame. We have to be very mindful as well as the effect that stigmatizing language has on individuals living with mental health problems. We want to be very mindful that we don't label somebody by their mental illness. Somebody is not a schizophrenic. Somebody is not a manic depressive. A person is an individual that lives with schizophrenia or lives with depression. That language piece also continues to add to the stigma when we start identifying people by their mental health problems. So we need to be very mindful of that language. We know that stigma, not just being that barrier to people seeking help, but stigma leads to exclusion, where people are not welcome possibly to functions. Stigma results in people not being able to find housing. But also, one of the very impactful things that happens with stigma is that starts leading to that self-stigma, whereas people actually start believing all those negative things that are said about them, said about individuals living with mental health problems. And when people start internalizing that, and we can go back to what Dr. Cassidy in those 5 points, 5 things we can do for that on that prescription card. One of them was positive thoughts. So if individuals are already struggling with mental health problems and they hear individuals using that stigmatizing language and they internalize that, imagine that the effect that it has on that person's thoughts, which then in result has an effect on their mental health. As well, the last bullet point here, unlikely to recover even with treatment. We talk about that, recovery is different for everybody. People can lead very full and happy lives living with mental health problems, but it's about having that support in their life and having people in their life that truly have a better understanding of what the individual is going through. But what we add on top of the stigma towards seniors living with mental health problems, another added component to that is the ageism. And when we take a look at ageism, ageism is those stereotypes and prejudices that are applied to seniors based solely on their age. And this is where people have the misbelief that, seniors, that it's too late or it's not important enough to provide that, promoting that healthy living. It's never too late. We certainly can have an impact and change a person's life to have a more positive and a more healthy living, as long as they have those good supports in their life. The other thing that we see with ageism is that it's particularly prevalent in those healthcare settings. But what happens then is that when ageism is put on top of that stigma, that it decreases that person's motivation, their feelings of self-worth, their quality of life, and their cognitive performances. One of the things that I've heard, from when I deliver the seniors course is that from some of the formal caregivers, those professional caregivers, is, you might have a senior that's living with symptoms of dementia and it's, depression. We often hear the overshadowing where, oh, it's just the dementia. That's why we're seeing the behavior that we are. Or it's just dementia. That's why they're saying the things they're saying. But we have to be mindful of is that when we look at, for example, depression, delirium, and dementia, the symptoms, the signs and symptoms of those of the three of them, they cross over in all three categories. So we really need to be mindful of the support that we're giving to seniors and realizing that everybody deserves to live the most healthiest life that they possibly can, and that we can play a role in that as well. So this quote, some people are old at 18, some are young at 90. Time is a concept that humans created, and it's very true, People think once you hit 65 that's it. When you talk to some people 65, they're now the golden years, they're going to start to enjoy their life. And this is where we need to look at seniors as one person at a time. We know that we can have two seniors, one 80, both of them 80. One might be in long-term care, one might be out running a marathon. And this is where we can't clump a group together and say this is the way everybody is. So just being very mindful of that. And one of the things that I want to touch on is that social health, and we touch upon this in our seniors course. And that refers to the individual's ability to positively interact with others. And when we have that social health, and we talk about that even on the prescription, the 5 things that we can do, social health is part of that. We know that socially healthy seniors can have, those meaningful relationships, socialize, make friends, be able to give and receive emotional support. It was interesting, one of the pilots that we facilitated a few years ago, there was a senior there who was close to 90, and she was there because she wanted to learn how to be a support to her friends in her retirement residence. So we all have that ability to be a support to others. But what we see with seniors is that they experience poor social health. And that's because seniors deal more frequently with losses, whether it's loss of a spouse, loss of a partner, but there's also different losses. Somebody who's retired and there's the loss of that. Or maybe, children have moved away, so there's losses, the loss of a pet. So there's different losses that a senior goes through. We know that seniors with those smaller social networks are more vulnerable to that poor social health, which then can cause that senior to experience more anxiety, more depressive thoughts, which then puts them more at risk for developing mental health disorders, more at risk for suicide, or can put them more at risk for experiencing more intense symptoms of the mental health problems that they're currently living with. So what are the aims of our course? So we break them down into 5. Obviously, recognizing symptoms of mental health problems, how to provide that initial help, how to guide a senior and or caregiver towards appropriate professional help. And that's what I said earlier, is that this course, it focuses on that informal caregiver as much as it focuses on the senior, and how to provide strategies and resources to support both the senior and their caregiver. So the course outline, as I said, it's a 2-day course. It's a 14-hour delivery. So day 1, we talk about what is the senior. We really break that down, talk more about that social health piece. And then we get into the mental health first aid. So how do we provide that support? We go over substance-related and mood-related disorders on day 1. Day 2, we touch on anxiety-related disorders, and then the dementia, delirium, and psychosis. So what's new in this course that it pertains specifically to seniors is that dementia and that delirium piece, which is not covered in any of our other mental health first aid courses. So when we take a look at each section, so we have artwork, and the artwork in each of our sections is actually from seniors. that live with mental health problems. One of the CMHAs in Ontario was kind enough to donate the artwork to us for this course. We go over the overview of the disorder, the variations, signs and symptoms. So what are those changes in behavior that we need to be aware of as those mental health first aiders? The impact that that mental health problem has on that person's life. What are those risk factors? Relevant concurrence, so we talk about that substance-related disorder and how it can affect living, let's say, for example, with a depressive disorder. We have some role play videos, so how do we provide that support, case study, and activities in every section. So the 5 basic actions that we take a look at, so like with, we have our ABCs of CPR. Well, with our mental health first aid seniors, our acronym is ALIFE. So we teach about how do we assess that safety. And what is also unique to the seniors course is that we talk about that serious physical deterioration. We don't talk about that in the other courses, but we know, for example, somebody living with dementia, the early symptoms of dementia may forget to take medication or believe they haven't and take more medication. So we talk about, some of those physical issues that may come across as well. How to be that good non-judgmental listener, giving that information reassurance, facilitating support for the senior and caregiver, and then encouraging as well support for the senior and caregiver. But the one thing we talk about and really stress throughout the 2-day course is how can we be the best non-judgmental listeners as possible. I love this quote here. The most basic of all human needs is the need to understand and be understood. The best way to understand people is to listen to them. I think sometimes in a society we forget all of the knowledge and wisdom that our seniors have and that they can impart upon us. And that sometimes when somebody's having a rough day, that listening to them and providing that safe space, holding that safe space for them is truly all that an individual needs at that time. And being able to be an effective non-judgmental listener truly is one of the best things that all of us can offer to another person. The other thing I just want to touch on very quickly is that encourage support for the senior and the caregiver. We know that the caregiver challenges that are out there. One of the main barriers that we see is the lack of appropriate information and how to manage symptoms. So just want to share a very short story example with you. Is that 2.5 years ago my father had surgery, and my father at that time was 80 years old. And after his surgery, my father experienced delirium. Now, even though that I worked in the field for 20 years frontline, in my years of working frontline, I've never experienced supported somebody that was experienced delirium. And I can tell you that if it wasn't for delivering this course and learning about delirium and learning from the participants that come to each course that I've taught, I don't know if I would have been able to have as good of a conversation as I did with the nurses and truly understand what my father was going through, and not just being able to support my father in those days of the confusion and, as I said to him, some of his rambunctious behavior. It was also gave me the ability to support my mom. As you can imagine, it can be very overwhelming for a spouse to see their spouse going through confusion and not knowing the days and some of the rambunctious behavior my father had. But truly being able to have the understanding of delirium, it allowed me to be a better support to both my mom and dad. And so with our course, we see professionals that come to take the course, but it's not about those professionals. It's also about those caregivers. How can we impart those skills and the knowledge on caregivers that allow them to be the best support that they can be? So how can you take a course? So organizations certainly can set up an in-house course. You can attend a public course. So all of our instructors do post their courses online, and our website is just www.mhfa.ca. You can contact an instructor that's in your area. You're able to find our instructors online as well, or you can consider training members of your team to be instructors in-house. So there you have a couple options there. And becoming an instructor, so this is just a picture of what the website for the seniors. So as we see here, the criteria is there on the right-hand side. There's the application process. The requirement to apply to become an instructor for the course is a minimum of 2 years working in a frontline position, specifically working with seniors living with mental health problems. is one of the major criteria for that. All of our instructor trainings are posted online as well at the mhfa.ca website. So there it is, our list of public courses. If you are interested in organizing an in-house course, please feel free to email our business development team, and it's just bd@mentalhealthcommission.ca. If you just have some general information, you could just email the mhfa@mentalhealthcommission.ca as well. And just to touch upon, to leave as well as what Dr. Cassidy talked about was the self-care. As we know, we can't pour from an empty cup unless we take care of ourselves first. All of us wear many hats in our lives, in our personal lives and in our professional lives. We cannot be a support to those in our personal lives or our professional lives if we don't first take care of ourselves. So I challenge each of you today to take a look at what you do for yourself. And if you're having a hard time, putting together a list of even 5 things that you do for self-care, I challenge you to add something new to your list within the last month, and to realize that we need to take care of ourselves before we can support those among us. So I thank you for your time, and at this time I'm just going to turn it back over to Alexa.
Thank you so much, both Dr. Cassidy and Denise, for sharing about those 2 great examples of promotion and prevention within seniors' mental health. That was fantastic. We did have a couple of questions. So the first couple of questions are kind of similar, and they're directed to you, Dr. Cassidy. So in relation to the workshops that you offer along with your Fountain of Health programs, folks were wondering who accessed these workshops, how did you promote them, when were they run, day of week, that kind of thing.
Okay. The workshops were ran through a couple of grants that we received, and the current workshop series is being run with the support of a federal grant from New Horizons Canada, and in conjunction with the Medical Association of Nova Scotia. So what we could use, I think, in terms of the materials are really very shareable and packaged in the form of a PowerPoint with a toolkit, but there is a certain amount of kind of infrastructure needed to make sure the person has some training in running the group or running the workshop. We have had lay leaders, so just members of the public who are interested in providing leadership as a peer leader. We've run them with people who were working in affiliation with the Canadian Mental Health Association Nova Scotia chapter, so they're non-medical but have more of a professional role. And we've also now run them with retired physicians as leaders. And in each of the first 2 cases, we found there was, a significant change in participants' knowledge and application of the knowledge. So I think a lot of it is just about getting people together to talk about these topics, and there's a certain amount of natural energy that gets generated by just creating a safe space for people to, as Denise was saying, actually listen to each other and reflect on what they're currently doing for themselves and how they might take a step forward. So we don't have any sort of active funding to provide that training component beyond the project that's already funded. But certainly if you have ideas or suggestions or you're interested in how you might bring this to your own group, please write to us. So that would be at info@fountainofhealth.ca. You could reach out, just put your subject heading interested in the workshops and send your questions along, and we'll try to respond. Thank you.
Thank you so much, Dr. Cassidy. So we just have one more quick question, and then we will wrap up. And just for everybody's information, we will be sending out a link to the slides. So if you missed any piece of the presentation or the sound was choppy on your end, we will definitely send you those slides and the recorded version of the presentation so that you can make sure that you get all of the information. So the last question that we will have today is an interest in mental health for seniors in long-term care facilities that maybe can't do some physical activity. They're limited maybe in their ability to socialize, perhaps dementia or other factors are affecting them. So which of your findings, Dr. Cassidy, may apply to those individuals?
I'm sorry, I didn't quite follow that. Alexa, say it one more time.
So folks in long-term care facilities who may have their ability to do physical activity undermined by either a physical illness or dementia or different factors. Is there anything that you've found that could be used in that sort of scenario?
Oh, well, okay, that's a great question. So that self-rating I talked about to find out where people feel their strengths are, where their deficits are, is useful. Sometimes the idea is to go where their strengths are. So maybe they're not that physically active, but they're still cognitively intact and like reading or socializing. They can go where their strengths are, especially if there might be, let's say, a small component of movement in that. So more of a mild physical activity goal with a bit more benefit in some other domain so that doesn't overstretch. But it's very, very important to figure out where people are, where they are in their current state, and then just take one small step in a positive direction. So if the goal is to work on something physical, obviously it has to be within the scope of what that person is capable of and it's safe for them to do. So maybe it's chair movements or in the pool or whatever it might be. But any good rec therapist and physio would be able to help with programming that would be, appropriate for someone with physical limitations. And the key is keeping it doable, safe, and taking small steps with encouragement along the way. So as mentioned, if it's a physical activity that gives them some social benefits, then, if people are enjoying themselves and whatever they might be doing, they're far more likely to repeat it.
Thank you so much. So we're out of time for today. I know that people all have places to go, so out of respect for your time, we will end. However, if there has been more questions, which I believe there has, we will definitely get the answers to you in a follow-up email when we send out the recording of the webinar. So I'd like to thank Dr. Cassidy once again, as well as Denise, for sharing today, and each and every one of you who are able to make the time to attend. Thank you so much, and have a wonderful day.